For many parents, the moment medication is mentioned in a mental health conversation can feel like a turning point. It can raise a lot of questions. Is medication necessary? Does it mean things are more serious than we thought? And once we start, does that mean that our child will always need to take medication? Those questions are incredibly common, and they make sense. Most parents want to be thoughtful and cautious when it comes to anything that could affect their child's brain.
Today we're talking with psychiatrist and Compass Regional Medical Director, Dr. Alex Timchak, who works closely with patients and families asking these exact questions and more. We're going to walk through what psychiatric care looks like, how medication decisions are made, and how parents can think about treatment in a way that feels less intimidating. Alex, thank you so much for being here. To start, tell us a little bit about yourself, the work you do, all of that.
Hi, Beth. Hi, Britt. Thank you so much for having me. As you said, I'm a child and adolescent psychiatrist. I actually did all of my medical training in Chicago, my medical school at Loyola Stritch School of Medicine, then my adult psychiatry training at Northwestern, and then my child and adolescent fellowship also through Northwestern at Lurie Children's Hospital of Chicago. I feel like I got great training, but that led me to my role where actually I've been since I graduated fellowship, which has been at Compass Health Center. So for those who wonder, a psychiatrist versus a psychologist, it's an important distinction, and this comes up a lot. So psychiatrists have to go to medical school. So minimum of 4 years of medical school, minimum of 4 years of residency training. The first year of that residency training is in general internal medicine, and then 3 years of adult psychiatry training. For child psychiatry, you can do a 5-year total program, and that's what I did. So I did 3 years of adult training and then 2 years of fellowship. So it takes a long time, but the nice part is that you get a lot of experience, not just from the psychopharmacology perspective, but also medical comorbidities and learning to provide therapy. So that's how I came into the role at Compass, and I'm happy to be here.
Thank you so much for being here. Yeah, I think there are a lot of misconceptions about what a psychiatrist is. And like you said, they often get confused with psychologists, and psychiatrists are doctors. You went to medical school, you are a doctor. So I think that's a great distinction. Could you explain a little bit about the different role that a psychiatrist can play within the mental health care continuum? A psychiatrist that is providing outpatient sessions, maybe it's on a monthly basis or what have you, versus a psychiatrist that's working with patients at the PHP, IOP level of care versus perhaps in an inpatient care facility.
Happy to do that, Britt. So a psychiatrist, well, I want to throw out a caveat as well. Psychiatrists are not the only ones who treat child, adolescent, young adult, and adult patients. Nurse practitioners and physician's assistants also can prescribe medications. They require a collaborating physician in most states, supervision from a medical provider, and at least that's the case in Illinois where I am. So a psychiatrist is often not the first person a parent might see unless they have a family friend or a neighbor who's worked with them. Oftentimes, pediatricians are the first port of call because they know your child and you know them, presumably. And relationships really matter, and feeling comfortable and trusting your medical provider with hard questions is paramount. I like to say that the definition of generalized anxiety disorder is being a parent. You're always going to worry about your kids. And so starting with talking to your pediatrician about concerns is very often the first point of care. And in fact, pediatricians do actually prescribe not just child and adolescent patients, but primary care doctors do for adults as well. And some of them are excellent and very comfortable and good at doing that. And others don't feel so comfortable just because the medication piece, the complicated term is psychopharmacology. There's a lot to consider. And that's what psychiatrists spend most of their training on, is spending a lot of time with these patients, interactions with medical issues and medications for asthma, diabetes, etc. And so pediatricians, that's not their specialty. So they might be comfortable starting medications, but if things don't go so well, oftentimes they will then refer them to an outpatient psychiatrist. Outpatient psychiatrists for child patients do 2 one-hour introductory sessions, one with the parents just to get an understanding of their concerns, talk about their past medical history for the child and the family, the psychiatric history, the social history, where do they go to school, how many siblings do they have, and also educational history as well. And so after that, they'll usually meet with the child for an hour and then talk about an initial treatment plan. Oftentimes they will want to talk with the pediatrician too, if they've actually been in care with them and working on or prescribing medications. And if you've already been working with a therapist or a counselor or even a tutor, sometimes the psychiatrist might ask to talk to them too, just to get the most expansive picture about what's going on so that can best inform a treatment plan. So my role at a PHP and IOP setting, those are acronyms for partial hospitalization program and intensive outpatient program. So usually patients come to this level of care when outpatient isn't enough, or they've been in the hospital and they still need support, but aren't ready to just go back to outpatient supports. So the difference is in an outpatient setting, usually after that first visit, if a medication is prescribed, then you will need to follow up with a psychiatrist about probably from anywhere from 2 to 4 weeks after that initial visit. And depending on how things go, it can be anywhere from 4 weeks to 3 months after that. Because again, a lot happens in a child's life in a short period of time, and especially during the school year. And so wanting to have a good sense of how the treatment plan is working, whether or not that includes medication, especially in the beginning, it leads to closer follow-up, which of course, as a parent makes sense. You're going to have a lot of questions. You're going to want to know if the medicine, if you're on it, is working. So going back to my level of care, PHP, IOP, that's where patients are seen by a psychiatrist or nurse practitioner multiple times a week. And it's kind of like a school day for a partial hospitalization program. Oftentimes it's for patients who can't make it to school if their symptoms are really significant, if they're very depressed, if there's a lot of anxiety and school avoidance. And there's plenty of other reasons that we can go into later, but psychiatrists will typically see them at least 2 to 3 times a week in that role because again, we're worried about them. We want to make sure they're making progress. In my role, I don't just prescribe medications. I really strongly emphasize kids and parents learn and use skills, because we know from the research that therapy component often, either alone or with medication, leads to the best outcomes and symptom improvement. And so that's the frequency of visits at the PHP level of care. The intensive outpatient, it's at least 1 to 2 times a week. Those programs are less time. Oftentimes that's after school for anywhere from 3 to 5 days a week, where the child is functioning well enough to be in school, but still needs closer monitoring and support, which again can include medication.
I also am curious, is there a difference between how one would interact with a psychiatrist at the PHP IOP level and then inpatient, just to make that like full continuum distinction?
Inpatient psychiatry is the really the highest level of care, with some exceptions, but usually that's reserved for clinical situations where patients need 24-hour monitoring. That's where a patient is so depressed and suicidal that even staying at home with close monitoring with their parents is not enough. Or if they're having psychotic symptoms and need IV medication or medications that have a higher risk of side effects, and the psychiatrist sees them every day in the inpatient unit. Those lengths of stay are usually shorter. When I was in training, it was 1 to 2 weeks. They're usually 5 days or less now, depending on which stage you're in. Some might argue that's a good thing. I wouldn't want to be apart from my kids for more than 5 days. But again, making sure that patients are stable and on the right track in the inpatient unit, that's expecting a lot in 5 days. But one of the nice things about, and part of the reason why I work in PHP and IOP, is that we don't have that hard and fast limit. We can work with patients for several weeks at a time, because not only is that going to lead to better outcomes, but we get to know them better. I see them multiple times a week and get to pick up from where we left off in conversations. We can follow them up with nursing, check their vitals, make sure they're doing okay, etc. The other piece too is that inpatient unit's in a hospital, and it feels like a hospital, which is hard, especially for a younger adolescence. I mean, it's scary. I mean, there's probably no better way to put it. To be apart from your parents, it might be the first time they've ever done that, and to talk to a doctor and be around other people that they don't know well. And it does have a role for safety and to achieve stability, but usually we really reserve that only in extreme cases where it's life or death, because that's a lot to put on a kiddo and their family.
I think that's so helpful to know, and it gives us so much context. Regardless of level of care, a lot of parents want to know, how should I know that it's time to maybe consider an evaluation for whether medication might be helpful? What are some of the things that go into that decision, and how might they think that they should talk to either a psychiatrist or, to your point, begin with a pediatrician about considering meds for their child or teen?
Yeah, it's a great question, Beth. When I had to put my oldest son, who's now in college, on asthma medication as a trained physician, like that was a big deal for me. So I absolutely acknowledge and don't want to minimize that any medication decision for your child is a big one. There is no cut and dry answer. You'll probably have noticed when you take your kids to the pediatrician, especially as they're coming into the tween years and early adolescent years, that they get time by themselves with the doctor or nurse practitioner where they fill out rating scales and where they're asking them questions about sexual activity, drug use, et cetera. So that is really an effort by the medical community to make sure that what has been written up a lot, that this crisis of mental health in adolescence is upon us and not missed, to try and make sure that we're capturing kids who are at risk, because oftentimes kids and adults struggle in silence. They don't like to talk about this stuff. They don't have the vocabulary to do it. They think that they're going to get in trouble. They think, that their parents might think that they're doing something wrong. Most of the time, parents will have known something is different with their child over the course of days or weeks. I mean, occasionally things are surprising, but baseline patterns of behavior start to shift. So that might be spending less time with their friends, spending more time in their room, more time on screens, being more irritable. Irritability is a huge hallmark of both depression and anxiety in children that may not present for adults. That's being reactive about basic things like, we want to have dinner with you. It's your birthday tomorrow. Let's talk about what we're going to do. And your teenager might get reactive, for example. So the rule of thumb in psychiatry for almost every diagnosis is impairment. You get the sense that my kiddo is really struggling, and I don't necessarily know why. And so if you're trying to talk to them and you're not getting a satisfactory answer, is I think when to bring it to the pediatrician. Communication with kids is hard. I mean, the goal of adolescence is to separate and individuate from your parents. And so when you feel that space and gulf getting deeper and deeper, and you see normal patterns of behavior where they might have been really bright and happy and going on bike rides with their friends, and they don't want to do that anymore and you don't know why, those are things that I would say is very unscientific, but as a parent, you have to trust your parent gut that something isn't right. And you're going to have peers and friends who might say, have you guys noticed that Tommy's, he's been a little down? And so trying to get some perspective from friends to kind of check yourself. I think those are good action steps. And I think really talking to your partner or your spouse about, I'm noticing that Tommy, this is not adding up. And then trying to talk to your child to say, hey, we're worried about you. What's going on? Because we noticed that you're not doing A, B, or C. So trying to use I language or we notice as opposed to you're not doing your homework, to try and open the door for kids that you're not in trouble. We're not mad at you, but we're just worried about you, and see where that takes you. And then if having that conversation isn't getting you anywhere, then saying, and maybe talking to your pediatrician again, or your community, maybe starting with therapy first. It's always a good idea to try and open doors of communication with your kiddo, because we know they're not going to share everything with us and they're going to hide stuff, as we did from our parents when we were growing up. But it is a way to say, we're worried about you and we're not sure what to do next. It shows some vulnerability as parents, and you're trying to open the door.
Can we also think about this from both for teens and also younger kids, which is maybe a different approach for when it's time, because they're not going to be able to identify some of what's going on and it's more behavior based?
Yes. Thank you, Beth. So behavior is communication. And oftentimes when kids are having a major shift in communication, they may not be able to identify what is wrong. And so acting out is a very broad spectrum, but dysregulated, disruptive behaviors in the classroom, not going to school, that is a behavior of a need not getting met. And that could be fear-based. Like I have, social anxiety where I feel like people are looking at me or judging me, and that's too scary. So it's so much easier to stay home. Or I'm being bullied, and so I take it out on my younger sibling, and I've never done that before. So those are things where, again, if you really get the parent gut check of something is definitely wrong, then again, just like if your child had a fever of a 104, you're probably not going to keep them home all weekend. That's a situation where this is a really big red flag and we need to get evaluated.
So I think we all kind of understand that there's a lot of stigma around mental health medication, right?
Yes.
I think oftentimes parents wouldn't hesitate to give their child an antibiotic for strep throat. You mentioned strep throat before. My 5-year-old's home with strep throat right now. So one of those things. But when it comes to mental health, there's so much stigma that comes with medication, psychiatry. And so I want to address that. Where does that come from, Dr. Timchak, in your opinion? Where does that start? I was born in the late 80s, and my parents carried with them a lot of stigma around mental health medication. And so I've done a lot of unlearning of all that. And so I would just love your opinion on the stigma side of mental health medication and how that plays into conversations that you have with parents when they are trying to consider whether a medication might be right for their child.
Yes. I hope you have 2 hours, Britt. I'm going to go kind of way back, but I think the field of psychiatry has a lot of historical, painful baggage that has kind of been baked into the social consciousness with good reason. I mean, people were getting lobotomies in the early part of the 20th century because we didn't have data. And at the best, you could say we were trying to help people. At the worst, people were being taken advantage of. And I think One Flew Over the Cuckoo's Nest, which ironically talks about ECT, electroconvulsive therapy, as something that harmed patients when, ironically speaking, and again, I know I'm biased here because I'm coming from the field, but for certain conditions, it's one of the gold standards for severely, severely ill patients. And so distrust of the medical field, I don't think is a bad thing. And that being said, most people go into this field not to experiment on anybody, but it's actually to provide support based on the best data that we have. So when people, I hear this, gosh, I can't even tell you how many times, but when you, to your point, a psychiatrist is going to make my child be a zombie, right? That word zombie is literally intimately connected with psychiatry because many people have had an aunt, an uncle, a parent who has been over medicated or improperly medicated, and they're skeptical. Fortunately, the internet and people's access to information, I think people have some sense about other medications out there, and there's more training now about risks, benefits, and side effects. That being said, treating children who have developing brains is a risky proposition, right? And so why would you put my son or daughter on this medication when you don't know what they're going to look like 20 years down the road is a very fair question. And so coming back to your question, Beth, is that usually the inflection point is that things are bad enough or hard enough that we have tried other interventions, hopefully therapy first, working with a pediatrician, where we are either concerned enough about ability to function in a normal developmental path, like can Tommy go to fourth grade or not? And he's missing all of his friends and he's staying at home and he's struggling every day. That's impacting his siblings. It's impacting us as a family. My wife might lose her job because she's out of FMLA because we can't get him to school. These are very real concerns. Now, that alone isn't a reason to say, all right, medication is the only way to do it. That's why I would say, again, therapy, if possible, is the first intervention, and then medication, usually in conjunction with, all right, can we do in-home supports for Tommy? But if not, coming to a place like a program, like a PHP program that's like a school day, because we want to do multiple things at once. I will be the first one to say that medications are not going to cure diseases in psychiatry. And it's hard to admit that, but let's use ADHD. We are not trying to rewire the brain. Their brains were born this way. It's not like medication is going to completely rewire them. That doesn't mean patients who have a diagnosis of ADHD or autism cannot live very full or functional lives. So what we have to do is treat symptoms. And that's the same for anxiety, for depression, for bipolar disorder, because we want to minimize the impact of their symptoms so that they can continue to grow and develop and become the young adults and adults we want them to be while minimizing the risk. It's not a right or wrong answer about prescribing medications. It's about risk versus benefit. There are no guarantees in psychiatry, but we know the safety profile, and there are many that are approved for kids. So again, as a parent myself and talking with parents as well, these are things that I touch on. I'm not hiding anything. I would say, I'm worried about Tommy too. We've tried A, B, and C. Now we need to think about D, E, and F. And these are options. I always give parents information to review and say, we don't have to make this decision now because this is a lot. And I also want them to feel as comfortable as possible asking me questions. If you're not there yet, I understand these are other things we can try. But if, again, a child is struggling so much that they can't use skills or in and out of the hospital, then I'm just very candid in saying we have few options left that we haven't tried. And there is a good chance that one or more of these medications can help alleviate symptoms so Tommy can feel like himself again, get back to hang out with his friends, get back to school.
Okay, so I have like 50 follow-up questions because you
Of
covered
course you do.
topics, and I'm writing them down. One of the things that I've always appreciated when working with you and sharing patients is that opportunity for discussion and the encouraging of parents and kids and teens of all ages to ask their questions, to share their concerns. How do parents sometimes it's just a matter of when can I get in a timely manner. But
Mhm.
what are some things to look for when parents are trying to find a psychiatrist that they can feel, or nurse practitioner that they can feel comfortable working with, knowing that this can be a hard thing to consider and to decide about?
For sure. So again, starting with your community, again, we can say a lot about this, but I think it's probably fair to say that most peers who have the same age kids will know of someone who struggled. And I know it's a very private thing. I mean, this is HIPAA protected information. Telling your friends that you're struggling with your child is not easy to do, but starting with people whom you trust, because it may not be them. It could be their uncle who's a pediatrician in the area who loves the psychiatrist who's worked with for 10 years. So I would do that because the life experience and interpersonal experience can be invaluable and save you some time. I think we're very fortunate in the Chicago area because there's a huge prevalence and availability of child psychiatrists. But again, I hate to be very realistic here, but the amount of counties in the US that have a child psychiatrist, it's only 71%. There is a massive crisis and shortage of child psychiatrists. One of the few glimmers of COVID is that many people are now available virtually, which for young kids is really hard, but for adolescents, it's more doable and easier because it's better access. So compared to even a few years ago, where you'd have to drive 30 minutes to an hour to go see someone, a lot of providers, both psychiatrists and nurse practitioners, will offer in-person visits and virtual visits. So that availability, I think, has helped a lot, not just in terms of, again, if you got two kids and one of them's in soccer and one of them's in dance, and you have to squeeze in a window to try and get to the, out of school to go to see the psychiatrist who's 45 minutes away, that's really hard to do. So the good news is that if you can find someone who has that flexibility, that tends to work. Some people, not very many, but will have Saturday hours as well. Those are really hard to come by, but you can find them as well. So yeah, I think those are things to get referrals or references from your pediatrician and from your peers or family members. And then again, starting with your magic wand list, like if I had someone who I could see in person to start, then maybe every other visit in person and they have Saturday hours, having a wish list would be great. And then kind of coming back down to reality. And all right, so this person is 30 minutes away, but they have virtual visits and my cousin sees them and loves them. That's a great place to start.
Yeah. And I think, what I'm also hearing is encouraging parents, regardless, to ask the questions that they want to ask and make sure that they feel comfortable talking to this person, whoever they select. You mentioned all kinds of diagnoses, but you talked about anxiety, you talked about ASD, you talked about ADHD, and oftentimes we see kids that maybe have more than one diagnosis, or we know that there are symptoms that overlap and we might not know which diagnosis it is. So for someone who maybe isn't as well versed with diagnoses in psychiatry, can you explain how a psychiatrist or nurse practitioner would go about deciding what to treat and how, knowing that there are different classes of medications and we might not always know what the symptom is a symptom of, or maybe there's two different comorbidities or two different diagnoses happening at the same time and we don't want to over-medicate? How do you decide what to treat and how?
Excellent question, Beth. And this is one of the greatest things about being a child psychiatrist and the hardest, because someone who's diagnosed with something with a diagnosis at 7 may not have it at 13. So we can thank the insurance companies in part for diagnoses because that's how they pay for things. But so diagnoses are labels that don't always and should not always stick. And there is something called the DSM-5, the Diagnostic and Statistical Manual, which is a big blue volume that was created by the organization, the American Psychiatric Association, to have it all in one place. So many years ago, when the newest version came out, two of the authors wrote an op-ed in the New York Times saying, yeah, this is all well and good now, but this is really like a field guide for us sitting on the Serengeti and watching lions and saying that we know the genetics of lions. So the point taken was that we still do not understand the fundamental genetic basis for most psychiatric disorders, which is a problem, right? And, for breast cancer, for example, we are getting there because we can now pinpoint things because we understand the genetics. That being said, there are many cancers, blood dyscrasias, other problems that we don't know either. So I don't want to say that psychiatry is alone in the universe as only a field guide. That being said, humans are good at pattern recognition. So a lot of the diagnosis in that diagnosis and statistical manual has centuries of patterns that we've seen that match up. So we kind of started sort of at the end, and now we're working backwards to the beginning of what the genetic, challenges are that lead to schizophrenia. But we know pretty strongly if someone starts to have symptoms at 18 where they are no longer talking, they're eating less, they're staying in their room, they're not interacting with their friends, and then they start saying that I'm hearing voices and that the devil is telling me to do things, having what's called a prodromal episode that leads to a schizophrenia diagnosis, that's pretty set in terms of we know what is going on. We don't have an ability to scan their head to say that, yes, confirming this is schizophrenia, nor can we take a blood test. Not yet. But those patterns are convincing, and that's what we do in our training. And then we see them and we get feedback from family members to say, okay, these are the things that it could be. Now, there are other things on the differential diagnosis. I don't know how many of you have watched The Pit, but it's not just always one. We have to rule out other things. So and they handled psychiatry pretty well, I'd have to say. But if a patient is, again, showing symptoms of auditory hallucinations and disorganization, there are medical reasons that could be underlying that. So if a parent came to me with Tommy in that situation, I would actually run a number of tests to rule out Wilson's disease, an intracranial lesion, like does he have a tumor, right? Is there an infection? So that's a psychiatrist's job as well. So it could be such severe depression that he's having a psychotic episode or major depressive disorder with psychotic features. And so those are things that go into a diagnosis. Now, if we found an underlying medical cause, in fact, I'm going to go ahead and quote The Pit for the influencer who was using a bunch of stuff from abroad that had a bunch of, I think it was mercury in it and was acting psychotic. Well, of course, this doesn't happen in real life in 2 hours, but if they chelate out the mercury, the psychotic symptoms resolved. And that's what they showed. And I think that was in season 1. So it was a good representation that there are other things that can cause a masquerade as psychotic symptoms. One of the things that we see a lot is that with the frequency and availability of high potency cannabis is that we've known for decades that can what's called unmask psychotic symptoms, bipolar disorders or schizophrenia. So I've had many patients that I've treated who have been very high functioning D1 scholarship kids, but used what's called shatter or dabs, basically almost pure cannabis oil, and gotten so psychotic they needed to be in the hospital for weeks. Now, if they remain free of using cannabis, is it possible that they would never have another episode? Yes, but we don't have the technology yet to guarantee that. So I bring up those examples as provisional nature of diagnoses is that we have to see what we have, take history from the family, from other doctors, and we have to give a provisional diagnosis. And we treat that, but it doesn't mean necessarily in 15 years, if all of those symptoms resolve, you're going to be saddled with that diagnosis forever.
Mm-hmm. I think that's really helpful to know that diagnoses can change over time. I think very simply what a lot of parents, when we think not necessarily schizophrenia and psychosis or those kinds of things, if a kid presents with, let's say, anxiety and ADHD, whether they're formally diagnosed or provisionally diagnosed, as the psychiatrist or nurse practitioner, how do you decide I'm going to treat one or both or overlapping symptoms?
It's hard because ADHD is the number one diagnosis in kids, is 9.5 to 11%. And many people might say that's because of the drug industry. I actually think it's not that. It's because of social media and the immediate dopamine that has exacerbated potentially symptoms where if kids did not have screens and immediate access to those things would not be as prevalent, but that's an aside. So ADHD followed by anxiety disorders. As I mentioned a few minutes ago, though, anxiety disorders are probably vastly underdiagnosed just because, again, you can have what's called subthreshold or subsyndromal symptoms where, Tommy might miss 1 day of school a week for 2 months, but not a whole week. And so parents are like, oh, he's having an off day, or he says he's got a stomach ache. So maybe he caught what his sister had. And so that's why he's not going to school. So that's where, again, we try and make sure we have the bigger picture. Parents might take him to the pediatrician and then get a GI evaluation, and that might actually show no pathology whatsoever. He might have an endoscopy, et cetera, try medications, when in reality, it was just anxiety. And he was saying that he wasn't saying, he was acting, remember, behavior is communication, that I'm anxious and my stomach hurts, because it really does, but it's from anxiety and he's not going to school. So trying to pinpoint in triage, just like excellent nurses, we have to triage what is the most pressing symptom first. So if a child or an adult is acutely suicidal, we need to make sure that they're safe before we treat their panic attacks. Or if someone is an acute alcohol withdrawal, but also depressed because they're getting divorced, we need to make sure they don't have a seizure and die. And then we can talk about the depression. So these are things that we have to evaluate. And going back to the PIT, that's the ER's job, right? They triage those things. I think it's hard because I think parents, in fact, there was an article in the Wall Street Journal a couple of days ago about how parents for highly competitive schools are getting really frustrated because every single child is applying for extra time on the SAT.
Yep. The parents of the kids who aren't getting extra time are getting very upset.
They are getting very upset. And I have a lot of feelings about that because working with many children who have severe ADHD, OCD, and other things who truly have impairment, it's not like that they need that to get a 1,600 on their SAT. They need it to get 1,000, right? They truly need it because the impairment is so much. So oftentimes ADHD will manifest or symptoms will be severe enough where the transition happens from learning to read to reading to learn. So 4th, 5th grade, but sometimes even sooner. And what happens is with kids with ADHD, oftentimes they're working so hard just to kind of hang with their peers, but they're so exhausted when they get home, they start to develop anxiety or mood disorders because life for them is really hard. So they keep forgetting their backpack or school ID. They keep getting detentions because they aren't in uniform. They keep forgetting to turn in their homework that they literally did and they just walked out. They literally were sitting in front of the teacher and walked out without turning it in. And so that gets really, really hard. And especially for girls too, they often get diagnosed much later because their symptoms aren't as externalizing as boys. So ADHD, it is really a tuned point, Beth, that ADHD and anxiety often go hand in hand. And so how I would diagnose those, I would want to get information, not just from the parents, but from the teachers. There's many rating scales, many which are free, but your pediatrician, your nurse practitioner, your psychiatrist will give you as parents, but also teachers to really try and get objective evidence because it has to be in more than one setting. It can't just be that Tommy's struggling at home. It has to be at school, at grandparents, at temple or at church as well to be able to diagnose it. I mean, it is truly a neurodevelopmental disorder of executive functioning. And so that manifests in all settings. So once you get feedback from that, then you decide, if I treat Tommy's ADHD, will the anxiety go away? Because if he remembers to turn in his homework, if he brings his ID to school, if he actually texts his friends back, and so his friends are like, oh, you're actually going to come hang out with us, will the anxiety symptoms resolve because he's feeling connected again? He's not worried that the world is against him. And so that takes some time in teasing out with parents. And sometimes we choose wrongly that maybe we should have treated the anxiety first instead of ADHD. One last comment there is that the pharmacotherapy for treating both, the timeframes are different. So many people are aware using stimulant medication is the mainstay for ADHD. Those work quickly. You would know within a week if it's working. Anxiety medication typically takes multiple weeks before we know it's working. So that does factor into the decision too.
And that can be really hard for parents. Not the ADHD works quickly piece, but the anxiety, because we get asked all the time, how long will it take to figure out what's the right medication to treat my child's anxiety and what's the right dose? And sometimes it takes, starting at one dose, waiting for it to become therapeutic, increasing the dose, then realizing we want to try a different medication. And that can be really hard. It's a long time to kind of trial and error it through several different medications.
Yeah, you're right, Beth. And I think that's where if a family member, if the mom has been on Zoloft or dad has been on Zoloft, which is a great medication for kids, it is approved for some disorders. It's actually not approved for anxiety disorders, but it is for OCD and depression. Then that's another challenge that drug companies haven't pursued FDA indications for a lot of these medications because it costs in the neighborhood of $1 billion to get that stamp of approval. But we know if a cousin, so Prozac, for example, can we use neighbors or cousins of those medications that it's called off-label prescribing?
If it works for mom or if it works for sibling, there's a good chance that
Correct.
it or a related drug will work.
Yes.
And that's maybe where you're starting.
Yes. Now, there is something called genetic testing. There is a way to take a cheek swab, some DNA, and they run it through a lab, and then you'll get a report that shows basically the enzymes in the liver that metabolize medications. And so this is getting better all the time, but the vast majority of these reports is not going to tell you this medicine is going to make all of my child's symptoms go away. I wish we had that. We don't, but it will tell you that this medication is likely going to be metabolized or processed as expected. versus this one that's not. I don't do it unless a patient has had multiple significant sensitivities or side effects for medications, or they've been through so many trials that we just don't know which direction to turn. There is a benefit though in that if we save the time of one trial that we had seen on the genetic testing probably wasn't a good idea, that's real time and that's real potential risk. I just wanted to throw that out there because it is a tool that can be valuable. It's not the panacea that the companies would want it to be. I wish it was. But again, that's why starting with parents or family members who've had success since there's shared genetics can actually help you not jump the line necessarily, but avoid medications that they maybe didn't tolerate, or help them and go directly to ones that have been well tolerated and helped.
Yeah. As the non-clinician here in this conversation, I think what I'm hearing overall is that medication is not always the first line of defense. However, sometimes it has to be if there is a situation where the symptoms are so severe that there actually isn't an opportunity to be able to learn the skills in therapy, to learn the coping skills, learn those tools to be able to manage the symptoms. So sometimes the medication has to be that first line of defense so that, like you said, a child who is struggling with ADHD can actually learn the skills. They can actually be in a place to learn those skills and start managing their symptoms, in conjunction with the medication. So let's talk about if I'm a parent and my child has been prescribed, let's, for example, take an anxiety medication. How do we know if it's working?
In addition to the macro level behavior, level of functioning, personality from parents, rating scales can be really helpful as well. Just saying, this is what your GAD, your PHQ, these are free available ones that we use in our system as well at Compass. But having the patient fill those out, it's an objective way for them to quantify their symptoms, and you add them up. And it's not always going to determine things, but it can be really helpful. Sometimes when language isn't working, these are research validated ones that can help guide the way.
How do we know if they're on the right medication? You hear these stories all the time where, my child was prescribed this and they actually got worse, or it took 6 different tries of different medication to find the right one and it was exhausting. And so I want to empathize with those parents as well that feel like they have had to try so many different paths to get to the right one for their child. How common is it that it's going to take a long time to find what works?
I don't know how common it is, partly because if me or other psychiatrist or nurse practitioner did a good job with their history and also a family history, usually you have a pretty good idea. In addition to that, there are practice parameters. So the American Academy of Child and Adolescent Psychiatry, not for every diagnosis, but has practice parameters that are really guidelines that say, with this diagnosis, this is the recommendation: first step, second step, third step. And, everyone has their favorite medications for different reasons, but most of the time people are going to be fairly close to the mark. Oftentimes when multiple failed trials happen, it's because, again, I mentioned sometimes patients are really highly sensitive, but it takes a lot to be patient. One of the famous psychiatry textbooks by Stephen Stahl, who's a very famous researcher and publishes a lot on psychopharmacology, it's the reference for all the psychiatrists. But in every medication, there's a section about side effects. The first 3 steps are wait, wait, wait. And then it says do other things. And there's so much truth to that, because for most medications, tolerance is the first goal versus efficacy. So let's talk about sertraline or Zoloft, which is very commonly prescribed for childhood anxiety, panic attacks, and depression. So SSRI, it's a selective serotonin reuptake inhibitor, tends to be well tolerated by most, but not all. And all of those medications in that class, GI upset, so nausea is a fairly common side effect, sometimes lightheadedness, dizziness, sometimes feeling tired. And those can last 1 to 2 weeks. Most child psychiatrists and nurse practitioners would start at a very low dose to minimize that risk. And so, but it might take you not just a 1.5 to 2 weeks to see if that's going to resolve, but you're not even getting close to an effective dose then. It's going to take several weeks. And for that class of medicines, Britt, it takes 4 to 6 weeks for what's considered an adequate trial and at an adequate dose. And so if Tommy had a lot of side effects, but I'm very candid with him, listen, dude, I get it, your stomach hurts, but if we stop now after 3 days, I can't tell you if this has worked or not. And so if it's bad enough that you say, I can't take anymore, great, we're going to stop it. We'll think about something else. But if you can give it a little bit more time, I want it to work, but it's your body. You have to tell me. And so that's how I have the conversation. And if parents say, oh, no, Tommy's throwing up every single morning right after he takes it. Those are things that help us determine the tolerability first. And so usually the vast majority of patients do pretty well on that class of medications though. And so let's say we're at the 4-week mark, and if parents are like, oh, he's not only not doing well, he's doing worse, and here's why, then I would say, okay, maybe this isn't the right fit. 4 weeks, it's not 6, but if we haven't seen any signal that he's getting better and the side effects are still a burden, then that would be a conversation about, we have 3 choices. We can stay the same, which we probably shouldn't do since we're worried about it. We can go up on it, or we could go down and consider switching. And Beth, you've heard me say this a million times, like the 3 hardest letters in psychiatry are N, O, and W, because we want our kids to feel better now. Like saying, oh yeah, it's going to be great. You're going to be a really good soccer player if you do this every day for 4 months. Like for adolescents, like you might as well tell them to learn Mandarin Chinese. Like that's ridiculous. And that's what we have to tell them. I mean, that's the reality.
And so, I mean, to piggyback on that, are meds forever? I think that's a fear as well. Okay, well, if we start this now, and they're feeling better, is this a forever thing?
Great.
Will they have to be on medication for the rest of their life?
That's an excellent question. So the answer is going to differ slightly depending on the diagnostic criteria, but for ADHD, chances are they will need it through college. A lot of people do discontinue in young adulthood and adulthood because they figure out a career path that works for their pattern of behavior, focus, and attention without having to take meds. But even for kids during school for ADHD, depending on how it's working for them, they might only need to take medicine Monday through Friday and take breaks on weekends. So there are some considerations there. There's some other diagnoses like OCD, bipolar disorder. It's probably going to be a longer time frame just to reduce the risk of impact and impairment, coming back to that word I've used a million times. But absolutely, it's always a conversation. I get nothing about keeping kids on medications. Like I tell them this all the time. I really don't care if you're on medication. I do care that you're doing well. So if we found one that's working, do we rock the boat? Do we make changes now? If so, fine. And why? And we need to feel aligned about, is this the right decision and the one that you're feeling most comfortable that lowers risk? If we're comfortable, then fine. There are very few long-term studies, Britt, about patients who have been on medications for a while. So Prozac, fluoxetine has been around since the 80s. It's the OG SSRI, and many people have been on it for many years. I know there's some stuff in the news now about antidepressants are the cause of every problem in America. I would disagree with that. But we do not have studies that show that long-term use leads to long-term deficits. Brings me to another one of my cheesy things that I've told Beth a million times, but my wife is a first grade teacher. You've probably heard this before, that the 3 greatest reasons of teaching are called June, July, and August. Well, the summertime is, and that's not why she teaches, but the summertime is one of the greatest things for child psychiatrists, because that is often when I would consider making changes or discontinuing meds. The most common time frame for a major depressive episode in adolescence is about 9 months, which shockingly corresponds to the school year. But if I saw someone in the fall started a medication and let's say by October they were doing better, what I would tell parents is that my recommendation is that we would keep you at this dose at least probably till the end of the school year. And here's why. Let's say they're doing great by October, and by Thanksgiving break, Tommy's like, Dr. T, like, I'm cured. You did a great job. He would never say that, but I want to stop my medication. And I would say, I understand. And this is the risk. And remember, I said there's not a right or wrong answer. I said, so let's say you stop your medication now, we would have to taper it off. So let's say he was on 100 milligrams of sertraline. I would lower it over several weeks and then stop it. And then let's say he does great through Thanksgiving, then it's wintertime in Chicago. And let's say this medication's out of his system. And then 6 weeks later, he comes to my office on January 15th and he's like, oh my God, I'm feeling terrible again. I would say, okay, maybe we should consider going back on the medication. Like there could be environmental factors that could have done that. His grandpa might have died or other things like that. But let's say that we feel convinced and parents feel convinced that the medicine really was helping. So then I would say we can start it again, but we don't get to pick up where you left off. It still might take 4 to 6 weeks to get you back. We can ramp up the dose fairly quickly, but to get to the neurochemistry to actually get to the equilibrium we were at before, it might take 4 to 6 weeks, which in a high school or even a middle schooler, that's a long time, especially if he's really struggling. So that's why to minimize risk of academic disruption, usually the summertime. And then sometimes a break between high school and college. Again, persistently reassessing. And once someone is stable in an outpatient setting, usually the minimum amount of time between a visit is about 6 months, but that should come up. It's like, okay, do we need to keep you on this medication?
I know there's also conversations about, you hear, I was prescribed this medication and it was working. working. I was feeling great. And then the person, since they are feeling so great, they want to go off of it, right? And so there must be a lot of, what's the right word? Repercussions of that too, right? I'm sure you see that a lot where
Yes,
it's
for
working,
sure.
I'm going to get off of it. Maybe with someone who's diagnosed with bipolar or something like that. I'm feeling great now. I
Did
don't
you
need.
know I was going to bring that up, right? Yeah, absolutely. So if patients say, "Hey, I'm doing great, doc. I want to stop my medication," it is actually incredibly common with patients with bipolar disorder because a lot of the medications do have a higher side effect burden, and also with patients with psychosis. Oftentimes, patients who have had a manic episode or a psychotic episode, in fact, arguably most of them, they do not remember. It's acute brain dysfunction, and the things that happened, the things they said, they won't remember and won't really have insight that I didn't get fired because I yelled at my boss. I got fired because I didn't show up when in fact it was a really bad episode that led to a hospitalization. So those are more challenging conversations, Britt, because, similar to, not the best analogy, but for someone who has to take chemotherapy, which is literally poison that kills fast acting cells for cells when someone has cancer. So telling someone you need to have 18 rounds of chemotherapy, it's like, I'm going to poison your body 18 rounds. Like that's hard for people to take. And for people having to come to terms with some diagnosis like a psychotic disorder or bipolar disorder, that is a lot. Those are diagnoses that can change. But once you've had a manic episode or multiple psychotic episodes, those are less likely to go away or to say that, we don't feel like that this is the case. And so for someone to know that I might have to take lifelong treatment for that, so I don't go in the hospital again, that leads to a lot of resistance. I mean, it's hard. And so really just trying to partner with patients and saying, again, like, I don't want you to experience side effects, but I don't want you to end up in the hospital again. I don't want you to go into 30 grand in debt because you went to Rivers Casino when you were manic. I'm not blaming you, but I want to protect you from those situations moving forward. And we know that the medicine is the best friend for you to do that. And the risk of the side effects is well worth the benefit. So these bad things don't happen again.
We talked a little bit earlier about how children's brains are still developing, and certainly throughout childhood, adolescence, and even into young adulthood, their brains are still developing and their bodies are still developing. Presumably, if they find a medication that is effective for them in childhood and their bodies and brains keep changing and hormone changes and all of those things, are they going to have to change medications or doses as their brains continue to, like, just to keep up? Or how do those things impact one another?
It's a good question, Beth. So there is this term called tachyphylaxis. It sounds like anaphylaxis, is a little bit
Say
different.
that for those of us who have no
Yes.
idea what you're talking about.
I was going to define it. So basically, it means that medicines that worked stopped working. And that can apply to multiple classes of medications. And you hear that fairly commonly. Like, I was on Zoloft for years and it stopped working. But going back to kids, I mean, sometimes dosage adjustments are part of it. It's not always a one-to-one relationship, but as a child grows and they were on a lower dose and then they're saying it's not working, but that is a consideration. And again, I'm coming back to what we don't know, but we actually don't have an understanding about why this happens for many medications. We do have some idea though. So these medicines work on receptors in your brain, and our brains are very smart in the cell envelopes, which means that after they've been bombarded by a medication, their receptors are what's called downgraded. And so there's less ability for the medicines to have the same effect because the mechanisms of the cells are smart enough to figure out, like, we're tired of being bombarded by this medication, so we're going to not have as much exposure. So we don't have the lock and key mechanism. And if the lock is on the cell membrane and the medication is the key, if there was 15,000 when you were 15 and 20 when you're 25, the medicine is not going to have the same benefit. So there's a lot yet we have to understand about that. Again, I'm not a clinical researcher, but that is thought to be one of the reasons why medicine stopped working.
How about if a child or teen is unsure about medication? Their parents are on board, their psychiatrist is on board, the team is on board, but the child or teen themselves is against it. They don't want to take anything. They're resistant. What do we do?
Just have them go on TikTok. They'll figure it out. It's an excellent question, and one I see almost every day. And I think jokingly reference TikTok, but I think there's a lot of 2-second mental health disclosure, etc. about I took this medicine and it ruined my life. And we know that's not the whole story. I mean, and oftentimes these are clickbait. And so you hear those messages 15, 20 times a day. You like one of them, and then your algorithm pushes 15 to them. Just a constant barrage of anti-medication stuff and just, eat beef tallow and everything's going to be fine. I mean, I've heard this in adolescents that I've worked with that, this isn't going to help me. And I've had patients who have said that for months and then finally realized, I'm thinking of someone with OCD, that I can't do this without medication. The contamination OCD was so bad. His hands were literally raw and bleeding because he was washing his hands probably hundreds of times a day, to the point where he was getting bad grades in school. He couldn't focus. And so finally said, okay, this isn't working and I need to try something else. So the goal is not for it to be like winning a battle saying, haha, you're doing what we're making you do. Like, no, it's really trying to partner with not only a child, but a teenager saying, like, this isn't about me making you do something you don't want to do. We've tried all these other things. And what you're telling me, Tommy, is that you still feel really bad and that you're really struggling. And I wish I could do something else, but this is what I have to offer. I mean, and don't you want to feel better? And I can't promise it's going to work, but we got to do something differently from what we're doing now. We got to try something else.
Yeah, I think that will be really helpful for parents to hear. I'm also curious, when do we involve others? So when do we involve teachers, coaches, other caregivers? If your child is on a medication for, say, maybe asthma, maybe you disclose that to the school nurse because you want them to know and be involved. When do we include those folks in a child's psychiatric treatment and medications? When do we need to kind of share that?
This actually kind of loops, maybe you intended to do this, right back to stigma. It's not as straightforward as it might seem, especially as kids get into high school, because if someone sees a med list and they don't know your child, they will form an opinion. And so I think for ADHD, teachers are going to know. I mean, they will absolutely know. And they will be actually very grateful to know that they're being treated, just because most elementary school teachers, they have big classrooms. And again, I think what often happens is that untreated kids, or as they're getting close to diagnosis, all kids want to do well, right? But if what happens is that their peers actually figured out, they don't know what it is, but if they know Tommy is going to freak out if I poke him in the back during a test, and he's going to be like, oh my God, who touched me? They're going to say, this is going to be really funny. And they're going to do it. And then Tommy's going to get screamed at by the teacher potentially, or the teachers would be like, Tommy, what is going on? And then he becomes a target. And he was trying to take his test, but because he's so impulsive and distractible, he was taken advantage of. And again, not like their friends are necessarily trying to bully him, but those situations, again, so the teachers are really going to have a strong idea about who's struggling. So I think the disclosure is when, and especially in high school, let me go back to OCD. So if someone is spending so much time checking their tests that they're not finishing their work, and you feel like, okay, we really need to get accommodations, or I really need to tell my math teacher because it's only in math and Tommy really struggles in math, then having that conversation can be really helpful. And in some cases too, depending on how far along you are, getting a neuropsychiatric evaluation, that those are batteries that are done by a neuropsychologist, not a psychiatrist, that goes through learning profiles, IQ, a number of different tests, in addition to looking at psychiatric diagnoses. Those really help schools. In fact, many of them require it to get services like a 504 IEP plan, because it really maps out in exquisite detail about what's going on. And teachers, again, will have some insight into this, but it will not only define what has shown up in the neuropsychologist's office, but will also give recommendations for accommodations. So Tommy needs to sit in the front of the class and surrounded by girls who don't like him, because then they're not going to bother him, or something like that, so that he is less at risk of being disruptive. And he needs extra time, especially for math. So again, this is not so he gets a 1600 on his SAT, but so he has a chance and a path to success in the classroom. So I think that's the point where if one particular teacher is really having a hard time, then talk to the school counselor, or maybe email the teacher and saying, can we have a discussion, because I want you to know what's going on with Tommy. And so it's not like you're looking to get a free A or anything like that. It's really just trying to partner with the teachers, because again, like we said, if it's ADHD or OCD, kiddos are struggling.
One of the things that I have loved in sharing patients with you is your ability to connect with kids and teens and to figure out how to instill hope in them and get them motivated and willing to participate in treatment, whether it's because they're too anxious to be involved or feeling too low. And I feel like there's a lot of Dr. T-isms that hold on to. I know we recently got a letter from a former patient. We see a lot of patients who are really struggling and really in crisis, that are suicidal or frozen in panic and truly not functioning. I would love for you to just share some of your Alex-isms that you give to patients or hopeless parents of any age to instill hope or increase willingness and motivation when the fear or the symptoms and illness itself are really acting as barriers?
Sure. I think the fundamental approach is that, I mean, I am very direct with kids and their parents. I don't have time to mess around, and I want to get to know them, and I want them to understand that, like, I hear you, I see you, and it really sucks where you are right now, and I'm on your team. So one of the things I think I already shared with, like, we understand that patients and their families want relief, NO&W, they want it now, and we can't promise that, but we're here to be on the journey with you, and it's not going to be a straightforward path necessarily. So, and it's going to be hard work. And so I think acknowledging that this is hard work, I think, especially for older kids, but sometimes for elementary school kids too, is that why I want you to use skills and sometimes take medication is that it's actually about what every teenager wants, which is control. So you don't want to be told what to do all the time by your parents, by teachers, everything else, nor do you want to be told what to do or not do because of your depression or your anxiety or OCD. So the skills are really meant to empower you, to give you agency and the ability to fight back and to say no to OCD, to have less panic attacks or less frequent or intense panic attacks, or to have less days where you spend 4 hours in bed before you do anything, because that doesn't feel good. That's why you're here. And as we can start to chip away, if it's 1% a day or even 0.5% a day, that's better than what it was before. And then one of the things too, and you mentioned that letter, is that I have said many times that depression is an episodic illness. There's some exceptions to that, but that means there's a beginning, middle, and an end. And I can't tell you where you're in the beginning of the middle or nearing the end. And sometimes, again, even without medication, that resolves, but you will not feel this way forever. And so this is also why in our program, we use cognitive behavioral therapy, dialectic behavioral therapy, and acceptance and commitment therapy, all these different pieces, because there's so many gems that we can pull from them. But really, again, is to say that you're seen, you're loved, and, we are here with you, and we know it's hard, and you are allowed to have a bad day. I say that all the time. Like, we're not blaming you. We know you don't feel good, but just because you feel this way today does not guarantee you're going to feel this way tomorrow. And, what can we do to work on that? What positive can we draw from today? Because we're fighting the battle with you.
I can imagine, and maybe I'm wrong, but especially with the rise of social media and everyone being chronically online, there is so many people out there that are prescribing these holistic ways to treat different mental health disorders. I'm targeted all the time for, like, give your child saffron for ADHD symptoms, or just like give them this herb or that herb. I'm sure that some of your time is spent educating folks on the validity of these claims that people are making on social media. Could you touch on that?
So there are some things out there that are low risk, right? Taking a daily vitamin is low risk. There's been so many studies that go back and forth about, does this extend your life? Does this reduce the incidence of cardiovascular disease? They seem to go back and forth. But with a lot of these different therapies, there just isn't a lot of data, and they oftentimes can be expensive. Again, I might sound like old school, U.S. medicine here, but I was not trained in complementary and alternative medicine. And there are some of those interventions that I've seen work. I am not an expert on them. And many people say, it's like, well, this is more organic or natural than sertraline or fluoxetine. And that's true, but also alcohol and nicotine are natural, and they've killed so many people. And we're not going to be prescribing you that. And so I think it's a conversation. I think largely the risks are going to be low, though I would say treating psychiatric disorders, broadly speaking, with cannabinoids, we're not there yet. There is promise, but study after study has shown that more often than not, it's going to exacerbate symptoms. But other things like turmeric and magnesium and other things, I think actually starting with your pediatrician would be a good conversation too, but also talking to your psychiatric provider as well. In some cases, it would be worth consideration. In fact, there is a supplement that I do use. There have been some positive studies. It's called N-acetylcysteine. I don't use it a lot, but I'm not opposed to using all supplements because it has shown to have some benefit for cannabis cravings, in addition to some other well-known medical uses for like Tylenol overdose, et cetera. But for daily use, it has helped. And the risks are very low and doesn't really interact with other medications. I do strongly advise taking calcium and vitamin D gummies. That's a one supplement. I actually never test for vitamin D deficiency because everyone in Chicago has it.
Right.
So
Yeah.
if there's one supplement for adolescents, that's probably the one that's the least likely to cause problems and the most helpful. Again, what I would say is that the evidence base for most psychiatric medicines have gone through the FDA regulatory process, and they do require a lot of positive data and risk assessment before they are approved. And again, even if it's not approved for kids, but approved for adults, that's a very rigorous process as well. So that's why we often talk about these are the medicines that are approved, these ones are not approved, these ones are off label, and would always talk about the risks and benefits. And also, what do we do if we don't treat you with any medications? That should be part of the conversation too.
So we're talking about different types of treatment, and my mind always goes to like Eastern medicine. I'm very into acupuncture for myself and my kids. And at Compass, we also talk about things like seeds. So looking at diet, looking at physical activity, engaging in pro-social activities and hobbies and arts and expression. Like, what are things, I don't want to say proactively or preempt, like we're not going to prevent certain things from happening in terms of symptoms and diagnoses, but are there things that you recommend to all parents in general, and especially if their children are needing to consider medication or struggling with mental health issues? I don't know, are there lifestyle type things that really can only be helpful for managing some of the symptoms?
A cell phone / screen plan should be mandatory. And it's really hard as parents, right? And look, I get it. Like,
we did a whole episode on that. It's so important and it's hard. You're
yes.
Right.
And so that was my intentional, unintentional plug. But yes, I think being very candid and then checking what's on there, because some not nice things can happen. There's been several terrible stories about very high functioning adolescents who have been fished into scenarios where they've died by suicide because someone threatened them. I have pictures of you, and unless you send me $10,000, I'm going to out you to everyone. Like, so many terrible things that can happen. And so, yes, at a minimum, having a plan. And there's so many different functions of that. Adequate sleep. And especially when doom scrolling at 2 a.m, that is not going to lead to a good day. Not probably having a PlayStation 5 in their room or a PC. Sleep hygiene is one of the first things that I think starts to reveal symptoms of diagnoses or problems that would lead to needing to see a psychiatrist or nurse practitioner. All kids are going to want hot chips, right? Hot Cheetos, I get it, Takis. And, especially like the electric blue ones. Why are those always the number one pick? Like, I just don't understand. At least it's less Mountain Dew. But again, like I understand from a degree, and having a snack drawer makes sense. I also don't necessarily think that locking up food and having that rigorous stranglehold is going to lead to success, because they're just going to go to their friend's house and eat them. So again, trying to be very transparent and candid, like, we're going to get you guys some junk food, but when you burn through the fruit snacks, like, that's it. And I do think, again, sadly, the reality is most adolescents are on their phones 6 to 8 hours a day. Like, they find a way to be on, even if they're in the phone pocket at school. Having some regulated exercise, so whether or not that's dance, that's soccer, some movement, is really important. Gym memberships can start, I think, at 14 in some places, and they can be expensive, and people can have some thoughts about that, but it's a great place to be pro-social, not on your phone. And if you can get a habit of doing some cardio or something like that, most gyms are realizing that they don't want like 800 teenagers descending upon them. But if they've got a couple friends, if they're off season to go to the gym, I think that could be really healthy.
I want to ask a question that I think is another misconception that a lot of folks have, not just parents, but I want to address it in case any of our listeners are kind of coming into this conversation with this misconception. And it's that psychiatrists are in cahoots with drug companies and they want to prescribe medicine as a first line of defense because there's some sort of relationship there. Can we address that and level set with folks that may be coming into this conversation with that thought?
The generic maker of Zoloft, they've never paid for a lunch or a flight for me. That used to be rampant, much less so anymore. I mean, as someone who's been in these drug lectures, not for a while, they hire very qualified, strong clinical people to give these talks. And so, right, is there a dual agency there? Well, that speaker wanted to get paid for this and get a nice steak dinner, but also, do they really believe in the medication? So I can understand why it gets icky, but this also goes with GLP-1s and other medications out there. So I guess I can only speak for myself to say that, like, I have never been convinced one way or another that from the drug companies, like, they don't send me on trips. I mean, if I wanted to, I could. I guess, do that kind of work, but do my own independent research. I talk with my colleagues. I mentioned this earlier. We all have our favorites, but sometimes they stop being our favorites when we have a bad outcome or significant side effects. So I think the onus of being a good doctor or nurse practitioner is to be as informed as possible. And ironically, and this is where maybe the challenge is that those lectures, even though they're biased, are really good examples of where to meet colleagues and talk about it. So I understand, and I'm not judging people for going to them because they do want to learn. And when you're a busy clinician, and when you have kids and other responsibilities, it's hard to sit down and say, all right, it's Sunday at 3. I'm going to study about Rexulti. But if your colleagues are saying, hey, Alex, we're going to go to the Capitol Grill together. Do you want to go join? Because I know the speaker and he's talking about Rexulti. It's harder to say no to that. So I would say as an institution organization, psychiatry has moved away to try and have that bright line between it. But also the hard part is that research takes money. I can't begrudge drug companies that need to stay in existence to have the money to then divert to research to make more medications. There have been very few advances in psychiatry in the past few years. Ketamine Spravato is one of them, which is not the golden child. It still has some problems with it, but it has shown some benefit in acute suicidality. But that system, that economy is there for a reason. And we don't have a better one right now. So I have to keep that balanced when I think about it because I do want more research. I want suffering to be alleviated. And if we don't have any new medications, the ones we have now, some of which are great, some of which are pretty good, some of which are terrible. If there's no innovation there, patients are going to suffer. So that's the yin and yang of that question.
The key is that for the most part, providers, psychiatrists are doing their due diligence to make sure care is individualized for their patient. And they're, finding the best one for the patient and their symptoms. And so that's what I'm hearing there. Is there anything that we've missed that we didn't ask?
I'm thrilled in part that parents are asking and getting information about AI. I want to be very cautious, though, that we are not there yet. And just speak truthfully, we are starting to use AI to help speed productivity and just record and do ambient listening and stuff like that so that I can focus on the patient and not typing. But we are far from the point where AI, at least I'm comfortable with, is going to help in clinical decision making. But for parents, why wouldn't you go to Claude and ask like, okay, my patient is taking Cymbalta and Adderall, and is this a bad combination? I don't know how much AI everyone out there has used, but I have used it a fair amount. And it likes to say that I'm asking good questions all the time. And the tone I feel like is often that I'm asking the right questions. And however I'm leading with the question will say that you're right. I've done some tests with AI and I just would say be very careful because especially for medications that are not approved for kids, it will say very dire things that don't necessarily match up with clinical experience. Bring those questions to your provider. Because again, the question is, whom are you going to believe, Claude or me? And it doesn't have to be me, but if I'm presented with information that I disagree with, again, that's much better because the bottom line is I want the family and the patient and the parent to feel comfortable. And if you don't ask those questions and say, I have these concerns, some of which may have come from Claude, fine. But then I'm going to say, okay, yes, this medicine isn't approved for kids, but I've used it in thousands of kids and I think the risk is very low, but the risk is out there. So again, whatever decision you're comfortable with, but I am comfortable with it. I know these are the risks, but I think that what Claude said is a huge risk, I would say is a minor risk. And so that would just be part of the conversation. And many of the searches I've done so far have, I would say, erroneously escalated risk for some medications. Again, that's just my perspective, leaning on just a few years of experience though.
But I'm so glad you brought up AI because not only are parents using it, but also teens are using it too, right? Like they're chatting with AI about their mental health, maybe about medication, maybe about what their psychiatrist is saying or what, folks are saying. So I think it's so important to bring it up and just all the risks involved with it. Like you said, Claude can be so agreeable to all of our questions. So, where's the critical thinking there? And just to be so wary of it and just informed, right? So thank you for bringing that up. That's so important.
We talked about so many things today. And if there was just like one or two brief key takeaways that a parent listening who's maybe like, do I need to call a pediatrician or psychiatrist or consider meds? I'm scared or I'm not sure. What, like your one piece of advice or next step for them so that they can feel empowered and hopeful?
Sure. And I do want to throw in the obligatory but very important piece. And I say this to patients whenever I meet them for the first time. I talk about a safety plan, even if they've never talked about suicidal thoughts or other things like that. I ask them, what do you think my number one job is as a doctor? And they're like, to help kids? I'm like, yeah, well, that is true, but it's to keep you safe. And so can you promise that if you have thoughts that you might hurt yourself or someone else, you could tell someone here, tell your parents? That's pretty much verbatim what I'd say. So there is nothing worse or scarier than a parent being worried about their child's safety. And so I think think that's where, if that is an imminent risk, then your pediatrician might not be available. And so if you truly feel like you don't know if you can keep your child safe, that is a situation where you can go to an emergency room to be assessed. It's scary, but again, if you really don't know, and again, going back to your parent gut, imagine if you didn't do that and something bad happened, right? Doesn't mean they're going to be admitted. It doesn't mean that they're going to be put on medication. A high percentage of the time, they will be referred to a program like a PHP or IOP program where they can see a psychiatrist, nurse practitioner very quickly, sometimes even the first day. And so especially if things are so bad, that's a situation where you can call a program like a PHP or IOP program where they can see you. ERs, that's their job, to triage and assess, and then they will refer you to those programs. And so even if you're in an area where there's not a lot of psychiatrists, those are opportunities, and many programs have virtual offerings as well. They can do a virtual assessment if it's really critically important, if there's an urgent safety issue.
I would be remiss not to throw in that I do think, if appropriate, that is one of the benefits of contacting a PHP IOP, because there is immediate availability for assessment, and they're not necessarily going to say, like if someone calls Compass for an assessment, we'll say, okay, a clinician will meet with you, and we may say, you don't need this. Here's a list of other referrals. And if you do need this, you can start right away and you can see a psychiatrist tomorrow, which I think, when you are in a crisis state, having that sort of mental health urgent care can be so helpful.
We have the time to take a breath, to make sure that you're safe, to talk to parents, to talk to pediatricians, to talk to the therapist, and start to learn and teach them skills. And I say to parents and patients all the time, I'm like, that's our first job. And if we find the skills are not working well enough or fast enough, then we can talk about medication. When a family's in crisis, then they meet some dude who's going to talk to me about medication. Like, that doesn't feel great. So wanting to start to build that relationship, let them know that we're partnering with them. To me, again, I'm biased, but that's, I think, how it should be and how I would want it to be for my kids. So that's the acute situation. But I think most bigger health systems have a messaging system. So if you message your pediatrician saying, I'm worried about Tommy, can I come in? Maybe they can even get a call without an assessment. That's a way to start. And then again, you don't have to be definitive, but say, I'm worried about ADHD. Like, I've done some research. Is this anxiety? His grandfather had bipolar disorder. So to have that in a safe space with a pediatrician, there's no wrong questions there, and they can help guide you. I also think that a truncated version of that to your friends would be like, I think I need to talk to someone about Tommy. I'm worried about him. Do you guys know anybody like a therapist or a psychiatrist? I have already reached out to my pediatrician. Most, I would assume, of your good friends, if they had someone who they liked, would give you that number. And if all else fails, again, and I can say this because we do this here, but to go to a PHP and IOP to get assessed, if you're really worried, we can give you referrals for an outpatient provider if you're having trouble finding them on your own. And, our goal is to connect people, to help people. It's not to say, no, we can't help you. And that's what our mission is. We're trying to help people. And I know it can be really challenging to navigate, especially when you're really scared as a parent. So, there's also 911 and 988, although I would say that those are not as personal and local to help you, but 988 is actually really helpful for teens. Letting them know that's out there is probably not a bad idea.
I know we've been talking about medication for the last while here, and I also want to remind parents and anyone who's listening that it's also their choice, right? Just because they're coming to a place like Compass or seeing a psychiatrist, that medication isn't mandatory. It's a conversation, right? It's a conversation to determine what the best treatment plan is for that individual, and it's individualized conversation. So I just wanted to remind folks that also is a big part of this.
It does sound like Tommy really needs some.
Poor Tommy.
I think similar to if you had a conversation about what treatment plan, if you have breast cancer or pancreatic cancer, like, these are big decisions. And very rarely do you need to make a decision like that. You wanting to sit with it, wanting to talk it over with your spouse or partner, wanting to talk it over with your parents, wanting to talk it over with your siblings. Again, the more informed you are about both the risks and benefits, like, the better treatment is going to go, right? And calling out your fears and concerns is ideal, because then you and your provider can address them together, right? This is not intended to be easy. Like, cancer conversations are not easy. Psychiatric interventions aren't always easy, but that's why I do this, because there is hope out there. We can oftentimes make things better. We don't always get good outcomes, but just being radically honest about it is my approach. And I think it works at least decently well. And I just try and respect the patients and their families. I owe them that. And sometimes they're taken aback by the approach, but I'm just like, hey guys, this is what we got. This is what we can do. And these are our options. And this is what I would recommend, but tell me what you think and let's come up with a plan together.
Yeah. Amazing. Well, thank you so much. This was a great conversation. I think that parents are going to get so much from it. the idea of medication brings up a lot of questions, and sometimes guilt, hesitation, or the pressure to make the right choice. That's completely understandable. When it's appropriate, medication isn't about changing who your child is. It's about reducing the symptoms that make it harder for them to regulate their emotions and build on the coping skills they're learning.
Mental health treatment is never one size fits all. Sometimes therapy is enough. Sometimes medication helps create enough stability for kids to use the skills they're learning. And sometimes it takes time to figure out which supports work best for each person and family.
We hope you leave this conversation feeling empowered to ask questions, take things at your own pace, and reach out for support. And remember, none of those things mean you've done anything wrong.
You do not have to have all of the answers right away. Stay curious and keep showing up for your children. That's what we're taking with us this week.
If today's conversation resonated with you, share it with someone who might need to hear it. And subscribe to You Only Know What You Know wherever you listen to your podcasts. It helps more parents and caregivers find us.
You can also follow us at Compass Health Center on social. We would love to hear from you. Send us a message or drop a comment and let us know what topics you're interested in. You're not alone in this. Thank you for being here, and we'll see you next time.